So after we spoke about in the previous video about how we stabilize the long-acting insulin, now we're gonna go back and ask about the short-acting and how we can as well adjust the short-acting as well. We're gonna talk again to Professor Zakir Mahmood. So thank you.
Hello. So we discussed previously about the basal insulin, and this is in a type 2 patient who was insulin depleted. So what will happen is that you will be fine with this regime with oral therapies and basal insulin for a time being, and then after a while your HbA1c will go up. So what you need to do is to ask the patient to start measuring their 2 hours postprandial blood glucose levels. So they will measure the blood glucose level 2 hours after breakfast, after lunch, and after dinner. So you will then typically see that the biggest meal of the day will have the highest peak. So they will have what we call postprandial glucose excursion. For example, like in the breakfast time, the blood sugar will go up to about say 10 or 9, at lunchtime about 11, but you see that the dinner time it goes up to 20, 22, 18, something like that. So straight away you know that this meal time needs to be covered with a short acting insulin, because pumping up the basal will not cut it. All it will do is then give a hypo in the morning. So do not do that, because that is all set. What the patient now needs is a specific targeted insulin across that meal time, which was showing postprandial excursion. So type 2 patients don't necessarily need to go on to 3 short acting straight away. They can go in a succession slowly. So you first cover the meal time, which has got the highest postprandial peak. So we take the example that this person had not so high at breakfast after lunch, but the dinner was very high. So say you'd have the patient going up to about 22. So we start this patient on a short acting insulin, and there are many of them available. We normally like to use an analog insulin because they have a better profile, lesser hypoglycemia potential, so they work quite quickly. So choose any of them which are available. NovoRapid, they are biosimilar. NovoRapid now, like TruRapid, Humalog, whichever one you prefer. So choose an insulin which is analog, short acting, and give specific instructions to the patients, because the activation time is quite quick with them. So what patients do, biggest mistake is they inject and then they wait for the food, especially they go to a restaurant, and then in the meantime they get a hypo because the food can be not guaranteed to come within the 5 minutes. So this is a rapid acting insulin. It will action rapidly in the body. So the minute they have injected, within the next 5 minutes they need to eat. So what I say to them is, don't inject until you see the food. So food is arrived on the table, then inject and leave it for 5 minutes, and within the next 5 minutes, or you can just eat quite soon after injection. So inject and have the food ready and then start eating, so that they don't really get a hypo because of the gap and the activation time. So that is the very clear instruction that you need to give. So inject quite quickly, within 5 to 15 minutes you need to start eating. So now what you do is you start with a very low dose. If you're really worried, just start with 2 units, for example, and 2 units will do nothing, but then it will just give you a comfort and the patient will be comfortable. So how you titrate is, then you measure the 2 hours postprandial levels. So again, you set a target of say less than 8.5 or 9. It should be single figures. Remember, this patient was shooting up to about 22, 18. So say, for example, this patient is given 4 units, and 2 hours after injection of the insulin and having the meal, the blood sugar has now come down from 22 to say 17. So you know that the insulin that was given was not adequate. So next time, tomorrow when they have dinner, they will up titrate the dose to about 6 units, and then again do the same exercise every single day up until they get a reading which falls into their target range, which is single figures and essentially around 8 or 9. Ideally, it should be less than 8.5. Once they get that, then they keep the same level of insulin. They can go up and down slightly. If they were to go and have a different type of meal or a bigger meal with more carbs, yes, they can increase it slightly. Or if they decide to eat a smaller meal, they can reduce the insulin. So it's pretty flexible. This is like a kind of rough and crude way of titrating short acting insulin in type 2 patients, but there are finer ways of doing it, and the finer way is about carb counting, which is typically done for type 1 patients, and we can do discussion on that in a different video. But this is how you start off. You start off with one meal, and then once this is settled, and then you now see that the HbA1c rises again, and then you pick out that the mealtime blood sugar readings after lunch is also going up, then you go on and add on the same insulin in the same process at lunchtime. Eventually, the patient will require at breakfast, at lunch, and dinner time. However, if the patient right at the outset is showing very high postprandial peaks after breakfast, very high double figures after lunch, high double figures, and after dinner, then there is no reason why you should withhold. You can just start by 2 units and increase to 4, and then go up steadily. And the patients are quite clever. They just learn to kind of titrate it. The important thing to tell the patients is very essential, that when they are going to exercise right after injection and the corresponding meal, they must take that into account and reduce the insulin. For example, if they were to go for moderate intensity exercise, so they have had a meal at lunchtime and they were supposed to inject 10, but they are thinking about going to exercise for about half an hour or about an hour. So generally speaking, if they're going to do half an hour exercise, they need to cut down their corrected or the calculated dose by 25%. So, if, for example, if they were to shoot or inject 10 units and they're going to do half an hour exercise, they mustn't give now 10, they should give about 7. So, about 25% later. Or if they're going to do 1 hour of exercise, they should actually rightly cut down their prandial dose or mealtime insulin by 50%. So, instead of giving 10 units, they should give 5 units. This way, they're going to avoid the hypoglycemia. The other thing is that never inject after coming out of a hot shower, because that will intensify the absorption of insulin and that will make the insulin to act more rapidly and it will not give the desired outcome. So these are important things. There are other issues about insulin technique which I can cover in a next video. I hope this is a little useful for you in terms of titration, understanding how do we intensify our therapies into basal and then bolus therapies. Thank you.